Hello, everyone. I'm Jennifer Littlefield, Director of Undergraduate Studies. For those that don't know, thank you so much for coming. We might have some more people come in, but I want to make sure that we stay on time because we have such a fantastic speaker today. We have in this group, as I can see, we have alumni, we have students, we have faculty, we have staff. It's really great to have so many different parts of our school represented for our very first Race, Equity, and Public Policy Speaker Series. Just want to say that this speaker series is new, and it's really meant to highlight the role that structural, institutional, and interpersonal racism plays in the development of public policy and the outcomes of public policy. It's multi-layered, it's intersectional, but it's critical to our understanding of policy. And these conversations are really essential in understanding the tools needed, what we need to do to combat this issue. Structural racism is a wicked problem, as we say in public policy. Plug for our Wicked Problems event every year. And it's one that's both urgent, but also longstanding. It's not new. So I just want to say that the School of Public Policy is really committed to raising awareness, to incorporating resources, both in terms of people, in terms of changing curriculum, in terms of research, all of these things. We're really committed to being a part of this work, and this series is one example. And I really can't think of a better way to get started than our speaker today. I'm just so excited. I'm going to turn it over to Katrina Walsman, who's going to introduce Dr. Sealy-Jefferson.
Thanks, Jennifer. I have the pleasure of introducing our impressive speaker today. Dr. Sealy-Jefferson is an associate professor at the Ohio State University's College of Public Health. She completed her PhD in epidemiological sciences at the University of Michigan and a postdoctoral fellowship at Wayne State University. She is a social epidemiologist whose primary research seeks action to combat manifestations of structural racism that limit the human rights of Black families and communities. She has several exciting and ongoing projects that aim to inform future intervention studies, policy change, and social activism. She's the founder, director, and principal investigator of the Social Epidemiology to Eliminate Disparities Lab that conducts high-quality epidemiological research to find solutions to the disproportionate burden of infant mortality among Black women. She's also the principal investigator of the Social Epidemiology to Combat Unjust Residential Eviction Studies funded by the Robert Wood Johnson Foundation, which she refers to also as SECURE. And the SECURE project aims to quantify the magnitude and severity of court-ordered and illegal residential evictions and their relationship with the health of Black families in Metro Detroit, Michigan. In her work, Dr. Sealy-Jefferson prioritizes community power and agency and centers the voices, experiences, and ways of knowing of Black women. We look forward to hearing from her today and welcome her to the University of Maryland School of Public Policy. And with that, I will turn it over.
Thank you so much, Dr. Walsman, for that introduction. And thank you all for the invitation today. All of you who are joining, thank you. I look forward to our discussion. I want to acknowledge that I am occupying the traditional homelands that were stolen from the Meskwaki or the Red Earth people. This statement is one small part of disrupting and dismantling colonial structures, as well as pervasive revisionist histories. I also understand that gender identity is not binary, and my reference to women throughout this talk is in keeping with the original self-identification of the study participants in the data set that I use. I would also like to acknowledge that the Professor Loretta Ross came to my talk at Smith College a couple years ago. And afterwards, she came up to me and said, "Girl, your work is the epidemiology of reproductive justice." So that's what I call my work now. So in the time that we have today, I will plan to discuss reproductive justice and several theoretical models that I use to ground my thinking about the problems that my work seeks solutions for. I'll talk specifically about preterm birth and racial inequities in this adverse birth outcome. I'll then give you some historical considerations that I think are important and key to understanding and imagining how we might intervene on the determinants of these racial inequities. Specifically, I'll talk about my work on neighborhood context, and I'll show you some examples from several of our neighborhood measures and their relationship with preterm birth. And then I'll talk about some public policy implications of this work, and as well as the work that I do in my in my teaching and my service, and then we'll have some time for discussion at the end. So let's start with reproductive justice, which is defined as the human right to maintain personal bodily autonomy, to have children, not have children, and parent the children we have in safe and sustainable communities. It was coined in Chicago in June of 1994 by the Women of African Descent for Reproductive Justice, and Professor Loretta Ross was one of them. It combines reproductive rights and social justice, and it's based on the United Nations Universal Declaration of Human Rights, which was a comprehensive body of law that detailed the rights of individuals as well as the responsibilities of government to protect those rights. And reproductive justice is not about choice, but about access, because we understand that the choices that people make are a function of the choices that they have. And reproductive justice is focused on all reproductive rights, not just abortion. So that includes contraception, comprehensive sex education, sexually transmitted infection prevention and care, alternative birth options, adequate prenatal and pregnancy care, domestic violence assistance, adequate wages to support our families, safe homes, and more. And a reproductive justice analysis draws attention to the ways that the history of white supremacy operates in a capitalistic system to affect the present reproductive lives of individuals and communities. And a conversation about intersectionality goes here too, because this framework illustrates how racial and gender oppression interact in the lives of Black women, and how gender is structured through race and class, and how Black women are targeted for multiple simultaneous oppressions. And intersectional analysis considers the interconnections not only as they influence individual identity and experience, but also as the systems themselves are entangled, co-constructed, and mutually dependent. The driving purpose behind an intersectional framework has always been how to examine how best to shift systems of power, not just how to better understand or describe these systems. Intersectionality helps us to appreciate how important transformation is, as well as building coalitions among different groups and working towards social justice, because only when we imagine the intersection of race and gender can we imagine the needs and perspectives of Black women and people, rather than focusing on what's immediate and proximal. A holistic intersectional approach helps us to ask the right questions as well as find the right solutions. So now I want to talk about fundamental cause theory, which was articulated by Lincoln Phelan to explain why the association between socioeconomic status and mortality has persisted over centuries, despite radical changes in the diseases and the risk factors that have been presumed to explain this relationship. So this theory causes us to specifically articulate the cause of the causes, or to think about the risks of the risks. An important implication of this theory is that health inequalities that result from a fundamental cause cannot be eradicated by addressing intervening mechanisms, because there are enduring inequalities in knowledge, money, power, prestige, and beneficial social connections that ensure that the mechanisms are reliably replaced. So fundamental causes have four essential features. The first is that they influence multiple disease outcomes. They affect these outcomes through multiple risk factors, and they involve access to resources that can be used to avoid risks or minimize the consequences of disease. And the relationship between the fundamental cause and health outcomes are reproduced over time through the replacement of these intervening mechanisms. So just so that we're all on the same page, systems of oppression are all of the isms. So racism, sexism, heteronormativity, classism, ableism, et cetera. The systems of oppression are systemic and directional power relationships among social groups in which one group benefits at the expense of other groups. And these systems are multiple and interlocking, and their interaction is complex rather than simply additive. So whereas that systems of oppression model identifies the scale at which oppression operates, so it operates among individuals who are embedded in institutions and they permeate cultures. This 5 faces of oppression model describes for us qualitatively how systems of oppression operate. So there's 5 faces of oppression. We have exploitation, which refers to the systematic transfer of resources from one group to another. Marginalization is the prevention or limitation of full participation in society. through exclusion from, for instance, the job market, healthcare system, public benefits programs, or community activities. Powerlessness is the deprivation of the ability to make decisions about one's living or working conditions. And then cultural imperialism is the valuing and enforcement of the dominant group's culture, norms, and characteristics. And then violence, which includes physical, sexual, and emotional violence, and the threat of violence, as well as policies and structures that condone violence. So it's important to note that some manifestations of oppression could be understood in terms of more than one of these spaces. And indeed, there is no hierarchy of oppression. These systems manifest in some ways that are similar and some ways that are different from each other. So all of this context is to frame what we see about social and health inequalities in the United States, what we know and what we have experienced in terms of health inequalities. We see here in this table that across various social determinants and adverse health outcomes, people who are members of the global majority compared to white people are made vulnerable and experience disadvantage in multiple ways. Our understanding of adverse health outcomes at the population level by race ethnicity has evolved from this idea that we see racialized expressions of biology, which refers to average biological differences between members of diverse racial and ethnic groups that are assumed to reflect some innate genetically determined differences, to biological expressions of racism, which is important because this reflects the lived experiences of racism, and it talks about how people literally embody and biologically express experiences of economic and social inequality from before they're born to the day they die. And this produces social inequalities in health across, like we just saw, a wide range and spectrum of outcomes and exposures. So of course, it's racism, not race. Race is a social rather than a biological construct. It refers to social groups that share cultural heritage and ancestry. This categorization is justified by ideology, and this ideology is really about one group benefiting from dominating other groups. And the identity of the dominant group is tied to this position of domination. And there are selective and quite arbitrary physical characteristics that are used to put these social constructs into place. And then W.E.B. Du Bois was talking about this at the turn of the century. There were large and enduring associations with health and mortality across racial groups. And this conversation that we're having today is not a new conversation. Racism then is the institutional and individual practices that create and reinforce oppressive systems of race relations. So Dr. Kamara Phyllis-Jones outlined for us the levels of racism. So there's 3 levels: institutionalized, which is different access to goods, services, and opportunities of society by race. Personally mediated racism refers to prejudice and discrimination. And internalized racism is when stigmatized groups accept negative messages about their own abilities and intrinsic worth. And internalized racism is characterized by people not believing in others who look like them, and people not believing in themselves and accepting limitations to their own humanity. We can understand the levels of racism and the difference between like personally mediated racism and structural racism by looking at this picture of an iceberg, where the tip of the iceberg represents acts of racism like burning crosses that are easily seen and individually mediated. The portion of the iceberg that lies below the water represents structural racism. It is more dangerous and harder to eliminate, and policies and interventions that change the iceberg's tip will not work, because structural racism is the macro level systems, social forces, institutions, ideologies, and processes that interact with one another to generate and reinforce inequalities among racial and ethnic groups. And structural mechanisms do not, in fact, need the actions or intent of people to be effective. So even if interpersonal discrimination or prejudice was completely eliminated, we would still see, and we have saw, persistent racial inequities that have not been changeable with interventions that are focused on implicit bias, for example. So systemic racism is in fact a fundamental cause of health inequalities. This is born from the economic advantages of slavery for white people when this nation was founded. Major institutions have been pervaded by racial stereotypes, ideas, emotions, practices, behaviors, and socioeconomic conditions that undergird systemic racism are reliably reproduced over time. There are flexible resources that advantage white people compared to other groups of people, including structural factors, individual resources of money, knowledge, power, and prestige, beneficial social connections, which are held disproportionately by white people, like the domination of whites in major government and commercial institutions, including elected and appointed government offices at national, state, and local levels, educational institutions, the penal and legal system, on and on. And then there are social psychological advantages, like expectations that white people should dominate, beliefs that white people are superior, and desires for social distance from Black and other people of color. And there are the broad range and flexibility of the resources that racism provides white people facilitates the reproduction of socioeconomic inequalities by race. And so this figure is showing us that systemic racism influences flexible resources through multiple replaceable mechanisms, which in turn affect racial differences in health through multiple replaceable mechanisms. So this figure is showing that systemic racism through multiple replaceable mechanisms is impacting racial differences in flexible resources and racial differences in socioeconomic status, but these two things do not completely overlap. And then through another set of mechanisms impact health outcomes and produce inequalities in health outcomes across time and groups and space. So there's been literature linking racism to poor health at the population level. So much of the scholarship has established multiple pathways by which racism harms health, involving adverse physical, social, economic exposures, as well as maladaptive coping behaviors and stereotype threat. Typically concurrent, these exposures can accumulate over the life course and across generations. So now I want to talk about preterm birth, which is the outcome that I spend a lot of my work focused on. It's defined as birth before 37 completed weeks of gestation. It's a multifactorial syndrome. Most of the preterm births are spontaneous, which means the traditional risk factors for preterm birth are not the cause of the spontaneous delivery or indicated, which means that the mother or the baby had a medical complication that necessitated the early delivery of the baby. And we don't know the exact etiology of preterm birth, but we know it's the second leading cause of infant death overall, and it's linked to adverse adult health outcomes. So the outcome of your birth dictates your later life chronic disease risk. And then there are stark and persistent and disgusting racial inequities in preterm birth, whereas it's the second leading cause of infant death overall, it's the leading cause of death for Black infants. Compared to other industrialized nations, the United States ranks poorly in terms of infant mortality rates. So this figure is showing you infant deaths per 1,000 live births over time from 1915 to 2017. And so I want to just point out that in 1916, Black mothers were 87% more likely to bury their babies before their first birthday than white women. And in 2017, Black mothers were 122% more likely to bury their babies before their first birthday than white women. 1916, 87%, 2017, 122% more likely. In order to understand and make sense of the stark and disgusting racial inequities in preterm birth in this case, but in all racial disparities in health, I argue that historical context is key. Here I'm showing you a timeline of the history of Black people in this country, with 1619 marking the first record of African chattel slavery here. From 1619 to 1964 was 345 years of inequitable treatment, poor health status, and inferior or absent medical care for Black people. The Civil Rights Act of 1964 was less than 60 years ago now, and it was supposed to end segregation in public places and ban employment discrimination on the basis of race, color, religion, sex, or national origin. And we have evidence that this legislation did not do what it was created to do. So the 14% of the history of African Americans in this country is post-Civil Rights Act. So historical context, as well as unequal starting points, have health impacts across generations, and the history of African Americans in this country is unlike that of any other racial or ethnic group. And this history matters for the current population levels of adverse health that we see. So this is a figure that I adapted from Ana Diaz-Rue and colleagues, and it's showing you a summary of the processes through which neighborhood physical and social environments could contribute to health and health inequalities. So first, we have residential segregation and socioeconomic status, which is dynamically related to inequalities in resource distribution. This impacts both the physical and social characteristics of a neighborhood, and these both impact behavioral factors, which is dynamically related to stress. And then we have personal characteristics like material and psychosocial resources, as well as biological attributes that impact all of the pieces of the system, and all of these things work together to impact health. So now let's talk about neighborhood context, which I study neighborhoods because we can do something about neighborhoods. They are important because they group together beneficial or non-beneficial circumstances for people, like healthy food, good medical care, recreational opportunities, or the lack of those things. Neighborhoods as a determinant of health was identified first in 1979 in the Surgeon General report. This report was a part of a comprehensive approach to disease prevention. And Williams and Collins in 2001 documented that racial segregation is in fact a fundamental cause of differences in health by racial group, because African-American or Black people live in starkly different neighborhoods than whites. These neighborhoods are often disadvantaged in multiple ways. And this relationship between neighborhood context and poor health and mortality is independent of individual level resources. So the way that we measure neighborhood effects is usually investigators link data from the US Census to address data, and we get sociodemographic characteristics like neighborhood poverty or unemployment. We can either analyze these as individual single items or create summary scores or indices. And there are advantages to using objective neighborhood measures in that they may capture important structural aspects of neighborhoods that residents cannot or do not perceive. For example, neighborhood disadvantage might shape access to local resources that consequently affect health, even if people have a generally positive appraisal of their neighborhood. One of the challenges, though, is that we have a wide range of neighborhood measures from the US Census that investigators use. So there's a lot of variability. I might be interested in the percentage of racial minorities in a neighborhood. Another investigator might be interested in the percentage of the population in the neighborhood who has graduated from high school. So what this limits our ability to do is to say whether and how neighborhoods matter for health at the population level. And another disadvantage is that the only data we can get from US Census is socioeconomic status data, and this may not equal the true neighborhood construct that we're interested in. So if you're using sociodemographic data to proxy neighborhood crime or neighborhood disorder, those are related. Those two things are related, but they are not equal proxies. And so we might not be measuring what we think we are measuring by limiting our quantification of neighborhood effects to data from the US Census. Alternatively, we can directly measure neighborhood characteristics by having trained observers go out and assess the housing stock quality, whether there's drug paraphernalia, whether there's graffiti on the walls, those types of things, or we can directly ask study participants about their perceptions of their residential environment. And we refer to this type of neighborhood measures as subjective neighborhood measures. So now I want to talk about the data that I use that I'm going to be presenting results from. I use the life course influences on fetal environment study, or the LIFE study. The original intent of this research was to quantify whether and how racism is related to preterm birth In Black or African-American women, we had 1,410 people participate. This represents 71% of the people who were approached for participation. This was a retrospective cohort study. Self-identified Black women were recruited in the immediate postpartum period, which means after they delivered their babies, but before they were discharged from the hospital, they completed all of the study materials. And we have surveys, medical records, current and prior addresses for the study participants. And they were eligible if they delivered a singleton birth at a suburban hospital. And they were excluded if they did not speak English, had intellectual disabilities, serious cognitive deficits, or any mental illness based on their report or based on our abstraction of the medical records. So this is showing you geographically where the women who participated in this study live. So we focused on Wayne, Oakland, and Macomb County. And then the colored map is showing you approximately across these 3 counties where each of the study participants lived. So this first study that I want to talk about is our analysis of women's perception of the physical and social residential environment and how this is related to preterm birth. So we thought that educational attainment would be a modifying factor for this relationship. And we examined women's perceptions of neighborhood walkability, food availability, safety, social cohesion, and social disorder. And all of these perceived neighborhood variables had acceptable internal consistency and reliability. So what we found, we were surprised that the traditional risk factors for preterm birth were not predictive of preterm birth in this sample. The mean age of our participants was 27 years. More than half were married or living with the father of their baby. More than 70% of the sample had at least 12 years of education. Yet more than half had annual income less than $35,000 per year. And then when we looked at the overall association between the 5 subjective neighborhood measures and preterm birth, we saw no evidence of an association in the overall sample, but we did see evidence that this relationship varied by educational attainment. So we stratified models by educational attainment, and the women with lower levels of education perceived neighborhood was associated with preterm birth in the expected direction. And we saw no strong evidence of association for women with higher levels of education. So in the lower educated group, less than or equal to 12 years of education, as they reported their neighborhoods to be more walkable, have more healthy food, and to be safer, they had lower preterm birth risk. And as they reported the social disorder to be higher, those women had higher preterm birth risk. So then we were like, okay, so for these associations, how do they operate? We hypothesized that psychosocial factors like depressive symptoms, psychological distress, and perceived stress might be on the pathway linking perceived neighborhood characteristics in preterm birth. So this is just a summary slide of what we found, that the relationship between perceived safety operated at least in part through depressive symptoms to impact preterm birth rate, and the relationship between perceived disorder and preterm birth appeared to be a direct effect net of the influence through any of the psychosocial factors that we examined. So then we switched gears to look at neighborhood disadvantage as measured by a neighborhood disadvantage index that I created from the American Community Survey and its relationship with preterm birth. And then we wanted to know whether this relationship varied by religious coping, because there's evidence that Black women use religious coping to deal with chronic stressors like neighborhood poverty, and because religiosity has been conceptualized as a social determinant of health. We thought that this relationship might be different by religious coping. So we had 3 questions, three domains of religious coping. Organizational religiosity was the frequency of church attendance. Non-organizational religiosity, we had 2 questions. The frequency that participants reported praying for themselves and asking other people for prayer. And then subjective religiosity was their satisfaction with the quality of the relationships with people in their church or place of worship. So what we found, again, no evidence of a main association between our neighborhood disadvantage index and risk of preterm birth. So this neighborhood disadvantage index was an optimally weighted index of disadvantage using 9 variables from the American Community Survey. But this relationship between neighborhood disadvantage and preterm birth varied by non-organizational religiosity, specifically women who lived in highly disadvantaged neighborhoods and infrequently asked other people for prayer had nearly 30% higher risk of preterm birth. So we thought that this non-organizational religiosity may buffer against the influences of living in a neighborhood with high summary measures of disadvantage, because this might be capturing a type of social support that is not covered in our traditional survey measures of social support. Really, these surveys, these scales were created for and validated in populations that are very different from this. So we think this is a proxy of some social support that might be the focus of future research. So then we know that life course influences matter for health. So we were interested in early life neighborhood context, the relationship with current perceptions of stress and preterm birth in Black women. So we had survey data on the women's, so they reported the quality of their early life neighborhood, so the neighborhood they lived in when they were 10 years old. So we thought the relationship between current perceptions of stress and preterm birth might be different based on early life reports of social disorder and social control. And we can talk more about this if people are interested. But what we found, again, no strong evidence of a relationship between perceived stress and preterm birth in this overall sample, but this relationship seemed to be different by early life social disorder, which is consistent with our other finding of a direct effect between current neighborhood disorder and preterm birth. So we saw women who reported high current perceptions of stress, plus who reported early life neighborhood social disorder had 31% higher risk of preterm birth. And we saw no strong evidence of association for the women who reported low early life social disorder. So then I was like, okay, what else matters? Other things matter. I was interested in neighborhood tax foreclosures and whether educational attainment modifies the relationship with preterm birth. Contextually, we know that the foreclosure crisis altered the social fabric of many neighborhoods in the United States in ways that might be connected to stress and preterm birth risk. And research suggests that living in neighborhoods with high foreclosure is associated with poor physical and mental health. And neighborhoods that experience elevated home foreclosure do have high community stressors like abandoned properties, crime, decreased community resources, including home values, family wealth, tax revenue, stability, and social capital. So this is just conceptually what we did. I linked survey and medical record data to the archival block group level tax foreclosure data from the county treasurer for a subset of the original sample. And this is absolute number of tax foreclosures, because I unfortunately lacked appropriate data for the denominator to calculate true rates for this analysis. Again, we found, so this is something that I think is important to highlight. There were weak correlations between the neighborhood tax foreclosure measure and the other subjective and objective neighborhood measures that we found. So this suggests that each of these neighborhood measures, subjective, objective, tax foreclosure, and I'm going to talk about other neighborhood measures, that they are capturing importantly different characteristics of the residential environments that our study participants lived in. There was no strong evidence of association between tax foreclosure and preterm birth in the overall sample, but higher educational attainment might be protective. We saw evidence of some effect modification by educational attainment. So tax foreclosures capture extended divestment and neighborhood decline and may cause spillover effects on health for residents. And in this paper, we focused on community assets and resilience as a reframe to the doom and gloom, and Black people have nothing and we can't persist and we don't have any hope. So this paper really tried to focus on reframing educational attainment. Education is not the great equalizer, but in this sample, we saw some suggestion of protection from this type of neighborhood stressor that might be scaled up. So then I was interested in neighborhood level mass incarceration and future preterm birth risk in Black women. The United States is unfortunately exceptional in incarcerating its own residents. From 1978 to 2009, the number of people in federal and state prisons increased 430%. 50% of Black women have an imprisoned relative compared to 12% of their white counterparts. And many urban areas are deemed $1 million blocks because at least 1 million taxpayer dollars are spent annually incarcerating residents of a single city block. We know that mass incarceration is a dominant social determinant of health because it punishes accused offenders and is a fundamental cause of persistent inequity. And neighborhoods with elevated incarceration rates also have poor population health like asthma, STDs, psychiatric morbidity, as well as increased crime rates. And we know that mass incarceration as a type of structural, as a strong and potent type of structural racism is a reflector of and a participator in the structuring of racial inequalities in this country. So this is conceptually what we did. We had zip code level mass incarceration data on 8 variables from the Justice Atlas of Sentencing and Corrections. And this is in the preconception period. I was able to link these mass incarceration data to data from the life study. So we had current addresses as well as addresses from the 2 years before they enrolled in the study. So I was able to match zip code level mass incarceration rates to the address that the women lived in 2008. And these rates are expressed per 1,000 adults. So what we found, again, average prison admission costs were 10-fold higher than average in the zip codes that our study participants lived in. And there was little evidence of associations in the overall sample, but we saw that so we had 2 effect modification variables. Younger women who lived in neighborhoods with high prison admission costs had higher preterm birth rate, and married women who lived in neighborhoods with high prison admissions due to new court cases had lower preterm birth rate. So I want to talk a little bit about housing instability caused by evictions. We know that 2.3 million low-income renters per year are evicted. This is an important determinant of health. And what I'm talking about are formal evictions or landlord-initiated forced moves. We know that poor women of color, those with children, those that are victims of interpersonal and domestic violence have the highest risk of eviction. And Matthew Desmond, the sociologist who pioneered the study of evictions in society, said that eviction is to Black women what mass incarceration is to Black men. It's a cause and it's a consequence of poverty. So residential evictions are the most harmful source of housing instability. And we know that many people pay more than 50% of their income in rent, and only 1 in 4 families pays, only 25% of families who qualify for affordable housing assistance receive it, and 1 in 4 renting families pay more than 70% of their monthly income in rent, which is atrocious. So this figure is showing you a comparison of eviction rates over time for Michigan compared to the United States. And we see that from 2000 to 2016, the rates of eviction in Michigan were significantly higher than the rates in the United States overall. So we were interested in neighborhood evictions and the relationship with preterm birth. And we thought that being married to or living with the father of the baby might modify this relationship. And we connected data from the eviction lab from 2009 to 2011 to data from the life study. And we know that unmarried mothers have increased risk of adverse birth outcomes, including preterm birth, since marriage may increase access to health services, financial security, and social support. So we thought that this relationship might be different by this factor. So we found that eviction, again, like mass incarceration and some of the other neighborhood measures that we examined, the eviction filing and judgment rates were not strongly correlated with the other neighborhood variables that we previously examined. And we saw that the range of evictions in the neighborhoods that our study participants lived in, for eviction judgments, the range was 0 to 78 eviction judgments per 100 renter occupied homes. And for eviction filings, we saw between 0 and 132 eviction filings per 100 renter occupied homes. So this means that in some of these block groups, some of these homes had evictions filed against them more than once in a 12-year period. And we saw neighborhood eviction filings and judgments were not associated with preterm birth in the overall sample, but the results varied by marital or cohabiting status. So people who were married or living with the father of their baby and living in neighborhoods with high eviction filings had 25% higher preterm birth rate. And those who were married or living with the father of their baby living in high eviction judgment rates, high eviction judgment rate neighborhoods had 18% higher preterm birth rate. So we conclude from this scholarship that social factors do not operate in isolation, that neighborhoods are policy relevant and modifiable. This is a necessary component of a reproductive justice agenda. And these within group analyses that we did are important and necessary because they help us to identify risk and resilience or protective factors, as well as mediating pathways linking manifestations of structural and institutional racism to poor health at the population level. And then we shouldn't have to quantify all of the ways that adverse neighborhoods matter for the health of Black communities in order to intervene. We need data and we need action. So some of this is about elevating, raising our consciousness about these things that are not hidden in plain sight, but that are impacting people disproportionately in our country. So there's a saying, no data, no problem. We know we have a problem, so we do have to get this data, but we also need action. We don't need research just for the sake of publishing in scientific journals, but people are really suffering and we should pair data collection with action. So I want to talk a little bit about the SECURE study. This is a mixed methodology, community-based participatory research project. We are quantifying the magnitude and severity of evictions, court-ordered evictions, and illegal evictions on the health of Black women, families, and communities. We have a community advisory board of Black women stakeholders from various sectors and community-based organizations. And I'm funding Black women consultants to co-create the work. 71% of this budget is going from my institution to the community in the form of funding my students, paying consultants, and paying the community members who will share their stories with us. So we have 2 projects, one focused on court-ordered eviction, where we're going to be using some secondary data analysis from LIFE and the eviction study, the eviction lab, and then we're doing some primary data. So we have surveys and focus groups for women in the Tri-County area. And then for the illegal evictions, we'll be capturing that with surveys and in-depth interviews with women who have experienced an illegal eviction. So there are clear public policy implications to this work. Hopefully I don't need to describe all of those ways, but I am attempting to name who and what is responsible, because we understand it should be clear that it's not people's behaviors. It's also not some genetic predisposition to poor health and mortality for communities of color, but it is the actions as well as the inactions of government. And we are focusing on human rights, human dignity, and morality as a way to elevate our collective consciousness about how we got to this point of worsening inequities in health. Preterm birth, infant mortality is what I'm talking about, but we could talk about any outcome. And we're focusing on policy relevant macro social determinants, and that is a policy choice, and how it is a policy choice to ignore the history of this country and to blame the oppressed communities for their oppression. This work is problem-driven, action-oriented, interdisciplinary scholarship that leverages the learnings from sociology, psychology, history, urban planning, and other disciplines to connect the dots across disciplinary boundaries, because we see worsening inequities by race, and we cannot do things the way that they've always been done and expect different results. I also use the scholarship on teaching and learning in the design phase of my courses, which I think is important to create inclusive teaching and to use inclusive teaching methodologies to make sure that all students have equal opportunity to achieve the learning objectives and to be successful in the courses. This is important for first generation and first-generation students and people who have identities that are underrepresented in academia. And my presence here and my specific attention to these inequities in student achievement can be addressed by committing to inclusive teaching methodologies. I also had the privilege of developing a social epidemiology course for undergraduates. So I'm the only social epidemiologist on my campus. I knew that. I was recruited to come to Ohio State because there were no social epidemiologists in there. And these students were furious that they had never had a course cover the concepts of social epidemiology. And so my teaching of this course, it has public policy implications because we're talking about who and what is responsible, about how our society is organized and how that organization is related to population health and health inequalities that are not intractable, that we can do something about. And then I have served on admissions committees at this institution and my prior one, and I use a holistic equity-informed frame to attempt to diversify our program, because it is time for this shift. We don't have enough people who are members of the global majority in these academic spaces. And the work is suffering, communities are suffering. We aren't having the impact that we and other taxpayers are funding this research and funding the work that we do. We aren't having the outcomes that we want. And so this is also part of the mission. I've also been leading and supporting the development and implementation of equity initiatives within the Ohio Policy Evaluation Network, which is a research collaborative focused on studying how policy affects reproductive health and equity in Ohio and the surrounding states. So this is also related to my work with my SEED lab, Social Epidemiology to Eliminate Disparities lab, which trains people ranging from high school through associate professor. And we seek to produce scholarship that informs intervention studies, policy change, social activism, and above all, the liberation of oppressed people. And then at the beginning of last year, I was sort of launched into this public thought leader role with my work and words cited in places like the Boston Globe, NPR, New York Times, NBC, CBS, ProPublica, and other places. I want to acknowledge the life study participants who trusted us with their data for the sake of finding solutions to the problem of preterm birth in Black women, as well as my SEED lab and my co-authors of the research that I presented to you today, and our funders. So we are funded by 2 grants from the National Institutes of Health, and then the Robert Wood Johnson Foundation is generously and they are revolutionizing, I think, how funding is done by giving me complete autonomy to do this project, the secure study, how I want to do it, where I want to do it, and supporting it 100%. So I want to acknowledge them. And I also am looking so forward to this conversation. So thank you all for being here, and I'm happy to take any questions. I'm going to stop my share.
Thank you so much. That was fantastic. Oh my gosh, what a bar you set for our speaker series. Terrific.
Thank you.
Yeah, thanks. If folks want to ask questions, they could do it in the raise the hand virtually. Ann Kaiser said she has a question through the chat. Ann, do you want to start us off?
Sure, thank you. And thank you so much for your talk today. I love the points you made about it being modifiable on the neighborhood message. And I agree with you that on so many policy issues that the structural racism you described is the root of the problem. And I don't disagree with who you said are the agents that are responsible. My then question is the then what? What are some of the policy solutions? Or is that your next step, or is that somebody else's research? I was just curious on the solutions.
Yeah, okay, thank you for that question. So this is not my solution. This is something that is sort of, in the public discourse. We need truth, reconciliation, and we need reparations. So I would say we need to start with that. you know, racism was declared a public health crisis in 2020. And it did not become a public health crisis in 2020. So I think that this conversation about the root cause, about the fundamental causes, is the step that has to be taken, because we've never been here. We've never, as a global society, declared racism a public health crisis. So I think reparations is step one, because people have accumulated intergenerational wealth in a way that was it's a function of exploitation, and people are unfairly privileged by racism, and people have been unfairly disadvantaged by racism. So some reckoning about that has to happen. Radical truth telling, radical intervention. But I think that righting the wrongs has to be part of the conversation, or we're going to just be focusing on the top of the iceberg that can be seen. And we're gonna, in 100 years, we're gonna still be having these same conversations. When I say we, they are still gonna be having these conversations in 100 years if we don't do the necessary deep work of figuring out. So people talk about health in all policies. I have been thinking about how it must be true then that there's racism in all policies. And so if that's true, then we got to figure out, how do we undo that? This country is founded on racism. The policies must be also deeply rooted in racism. So it's going to be some work. It took us 400 years to get here. I hope it's not going to take 400 years for us to sort of see a turnaround, but a radical truth telling and some reparations, I think, is in order.
Thank you so much. I think we have Ebony next.
Hello. Just wanted to, first of all, say thank you so much, sis, for being present. Hearing your voice, I just chills. So my question was actually taken by the previous commenter, because I wanted to know, were you aware of any of your research that had actually gone into any policy work? So thank you for explaining that. And just thank you for echoing a lot of what Dr. Dunning and I have said in our coursework. So it was really nice to hear that. So no more questions. It was just taken. So I just wanted to say thank you.
And the baby got to hear too, right?
Somewhat, yes. And he made it. So that was also very, very key as a new mother to hear that. That was actually one of my biggest fears going into childbirth. So it was important that I had Black women, a full Black woman team on my birth squad. So we could talk about that. But thank you.
Yes, thank you so much.
Thank you. Claire Dunning, you're next.
Thanks so much for this talk. It was phenomenal and aligned with things that Professor Johnson Cooper and I talk about in class. And so this was just a really wonderful, rich conversation. And I also had the policy question, so I'm grateful to Professor Kaiser for putting it on the table for us. So I'll ask my second question, which was around this question of data. And so you said that no data, no problem. But I also hear you having a much more capacious definition of what counts as data, right? No quantifiable data, no problem. But I also hear you saying, of course, Black women have been telling us this is a problem for a really long time. And so I'm wondering sort of how those voices show up, in particular your new study, Secure, I might be flipping the acronyms, but with the mixed methods and sort of how focus groups and lifting up not just the quantitative data, but the lived experience and the voices, how that's showing up and how you're going to sort of help us as a field of scholars push what we mean by data. Because I hear you telling us a couple different things, and I agree that data can take so many more forms. And so I'm wondering how that shows up in your scholarship and what you want us to think about what counts as knowledge.
Thank you. That is I love that question. Okay. You got it right. Secure study. In secure study, I am intentionally centering the various ways of knowing, various expertise of community. And I'm in an interesting place, okay? Because I am a Detroiter. I'm a Black woman. I am a member of the community that I'm doing my research in service of. So this is not conceptual for me. This problem that I'm focusing on is life or death for me and people who look like me and people who I care about and people whose lives matter. So the way I'm doing my work is I am seeing all of the ways in which these, okay, so let me just back up. The figure that I showed you, the infant mortality rates over time, tell me something very specific, that everything that has been done hasn't worked. That's what that data tells me. If 1916, Black women were 87% more likely to bury their babies before their first birthday, and in 2017, Black women were 122% more likely, that tells me everything that has been done hasn't worked at the population level. So to me, it's not logical for me to do research the way I was taught to do research, or the way that I see a lot of academics and people doing research. So when I got this opportunity to do a research project, by the way, the Robert Wood Johnson Foundation asked me what project I wanted to do. And so I'll just give you a little bit of background. I was at a conference and I gave a talk. It was 10 minutes. I got a standing ovation. The program officer at the foundation was in the room. She came up to me and said, "I want to find a way for us to fund you." Fast forward 1 year, they awarded me a $1 million grant that I didn't have to compete for, to do the project that I wanted to do, where I wanted to do it, how I wanted to do it, with complete autonomy and control of the budget. So what felt right to me was a research study that's for Black women, led, co-created, and conducted by Black women, centering the lived experiences and various ways of knowing of community, mixed methodology, because I'm an epidemiologist. We have a tradition of quantitative data, but that's not the whole story. I have, with my own research and reading scholarships, see that how much of the context is missing. So the context is missing. Also, what we're focusing on is appears to not be correct, because it's genetic predisposition to diseases, which we have a lot of evidence against that. We know that it's not behavioral factors. We know that. So I'm focusing on the macro social determinants. And then unfortunately, housing, before this pandemic was a housing instability was an issue. In this pandemic, it's even worse. So I think we also need to have a conversation about who is doing the thinking work. So I've said, you cannot be an expert on problems in a community that you are not a member of. If you want to be an expert in a community, on the problem that of a community that you are not a member of, you have to, I think you should ask yourself why you want that, because that's sort of rooted in colonialism. But that people from the communities that are disproportionately impacted by things need to be the ones who are doing the thinking work that is in service of their liberation, because that's never happened before. And we know from the data that everything that has been done in the past has not worked. People who are out here dying are going to tell the truth about what they're going through. And I have a responsibility, because I do have this position and I have this privilege, to tell the truth about what my people are experiencing, what we have experienced in the past, because this current moment is tied to all of the moments that came before it. This is about status quo disruption, and I think that's what it's going to take. So I encourage students not to look at the existing literature as the roadmap for like what you need to do. No, what hasn't been done. Let's try that, because people are dying.
You're getting a lot of head nods and some love in the chat, Dr. Sealy-Jefferson.
Thank you very much. And that's an exciting radical philanthropy of funding scholarship, amongst other things. Whew. Thank you for all of it.
Thank you. Next is Dean Orr, has his hand up.
Thank you very much. And Claire, I think the idea of a radical philanthropy is something that echoes well in this program with a lot of our folks that work on philanthropy. So thank you, Dr. Sealy-Jefferson, for using that example. It gives us a little hope that there are different ways to do philanthropy as well as do scholarship.
Appreciate that.
First, let me just thank you, Dr. Sealy-Jefferson, for a very bold, very powerful talk. You advertise that your scholarship is about how to shift systems of power, not just understand them. And that came through loud and clear. And I really want to call that out and thank you for it. I've done some work while at the UN on the global problems of maternal and infant mortality. And I've seen kind of the persistence of infant and maternal mortality across very different countries, very different systems, very different geographies and histories. I was really interested in your entry point into this issue. You made a very strong case for structural racism as a central cause in health inequalities in the US. How do you, given that oppression and the social determinants of health are both very complex systems, how do you separate out the effects of structural racism, the effects of some of the other isms, sexism, and social and socioeconomic inequalities? Because these are complex systems, it just seems so difficult to pull the different threads. How do you do that in your work? How do you think about that in your work?
Thank you so much for that question. I think, so I have a couple thoughts on this. So epidemiologists like independent effects. Like, we want to show that this, independent of other things, is related to this outcome. This exposure is related to this outcome. And so what that causes us to do is to be reductionist in a way that I think is not helpful. This system of structural racism that impacts every single sector of our society. And it impacts people of color, Black people in particular, in innumerable ways. Instead of resisting that complexity, we have to embrace the complexity and intervene where we can intervene to disrupt the system. I also think it is hard. So some people have sort of a resistance to social epidemiology as a subdiscipline in my discipline, because it's like, oh, the way society is organized cannot be changed. We can't do anything about income inequality, or we can't do anything about some of these policies, like mass incarceration as a manifestation of structural racism cannot be health promoting. Some of these things, to me, it's like some of this stuff is, how can mass incarceration be health promoting? How can neighborhood disadvantage, that by the way, is a function of redlining, that is a policy choice. These things are intentional. So some of it is like, we don't have to have all of these statistical complicated models to show that these things that we can obviously see are not related. If they were related to good health outcomes, they certainly wouldn't be concentrated in communities of color. I think we have to move past this sort of compulsion to have all of the empirical evidence, because we do see some of these things are clearly not in the best interest of society. All of us are paying for these inequities. So I've been trying to document some of these associations with numbers, because we have to have the documentation. But of course, in social epidemiology, I'm probably never going to do a randomized controlled trial. I'm never going to randomize people to live in neighborhoods that are impacted by mass incarceration compared to other people who are not. These things are unethical. So I think some of this conversation has to be about the morality of the social justice mission, of social policies that have roots in structural racism, that if we just told the truth about why does this policy exist? Why is it that in Wayne County, which is the county that Detroit in, which is the most segregated city in the country, why is it that when you call the police don't come? That's not by accident. Why is it that the schools are underfunded? Why is it that Black men are more likely to be locked up than any other group of people? Like, these things are, I think in academia, sometimes we overcomplicate it. But the reality is that these policies, practices, and procedures are killing people. And none of us are free unless all of us are free. So that's something that we just have to settle into. All of us are paying. Our humanity, our shared humanity is suffering because people are unfairly privileged by racism and people are unfairly disadvantaged by racism. So it's on us to be smart, to think about how can we intervene? We must. This is not, we cannot opt out of that. Some of these things don't need empirical documentation. Some of these things are clearly, it's wrong. It's disgusting. And we got to if we tell the truth about it, we can't unsee it. So then I hope, I'm very idealistic, but I hope we can have enough political will to act. Some of these things clearly are not health promoting. So then it's on us to help people understand that and to compel, to urge people who have the decision-making power to do something about it.
Thank you. Thank you so much. Catherine Worsnop, Kat.
Hi, thank you so much for this, and in particular for so eloquently connecting systemic racism to these horrible outcomes. So thank you, really. My question is, your work reminds me, obviously, without mistake, I'm sure, of other research on how much more likely Black women are to die in childbirth than others. And in particular, some research showing that basically nothing is protective of this, that like higher education doesn't help, having a spouse doesn't help, but basically it is about your race and nothing kind of helps you get over that higher likelihood of maternal mortality. And I always come away from kind of reading research on that feeling very depressed because, of course, but also because while I completely agree with you that the cause is systemic racism and that must be addressed, I don't want to have to wait for that to be addressed to fix these problems. And I'm wondering about whether and how you're using your research to think about some more short-term interventions that could address these problems while we are also addressing the larger and more central cause of systemic racism.
Thank you for that question. Oh, okay. So we're friends. I'm just gonna say something, okay? The responsibility to undo the impacts of racism is on white people. There's no other way. So we could have some short-term gains on this if we had enough people who are from the local majority, white people, to dismantle the racism that every white person benefits from. There's not enough Black people in this country. There's not enough people of color to do the heavy lifting of intervening on all of the ways that this country that is built on racism is manifesting racism. The political will to do that is going to be, and has been in the past, our limiting factor. Fundamental cause theory helps make it very, very clear that intervening on proximal causes, distal versus those things are not going to be effective. So intervening on social social support, intervening on behavioral factors, intervening on other things short of the root cause is not going to work. It'll make us feel good. It'll make us feel like we're doing something. Okay, but that data on infant mortality, like I said, that was the example today. We can look at inequities in health at the population level, no matter what outcome we're looking at, and we'll see that these inequities have persisted. So I can't speak for all Black people, but I'm going to say for my descendants, I would prefer that we do the heavy lifting now so that 3 generations from now, my descendants have an equal opportunity to live past the 1 year mark of having a baby or have their children live past their first birthday. I'm willing to wait on the real solutions because for generations, 400 years, people who have identities like mine have lived shorter, sicker lives, and we died more from everything. And that's going to continue unless we do the right thing now. And I say we, I mean, people who are from the majority population in this country. It's on that group because y'all benefit from racism. I don't benefit from racism. So and I'm oppressed by it. And people who have identities that are underrepresented, that are minoritized, that are made vulnerable, communities that are made vulnerable, cannot be responsible for being oppressed and coming up with solutions to that oppression. That is not logical. So short term, I know we want, because it's hard to look at, it's hard to think about, it's hard to see. And that's how we got to this point of inequities that have gotten worse. 1916 was a very specific point in the history of this country. That those inequities have gotten worse in 2017 compared to then, that's shocking. That's atrocious. It will continue because, but like I said, this moment is tied to all of the moments that came before it. History helps us to understand where we are right now. History also will help us to imagine a different future if we do some different actions. Like we need specific investment, we need policy change, we need, like I said, reparations, we need radical truth telling. We need people who are not members of oppressed groups to sit in the discomfort of what you see. Look at it. Tell yourself the truth about what you feel about it. Okay, you didn't enslave my ancestors. But your ancestors did. Like you got benefits from that. Like that's something that not a lot of people are willing to have a conversation about, but it's true. The intergenerational wealth that people have accumulated came from somewhere. It wasn't about hard work. So I think this is a hard conversation. But again, radical truth telling is the only way forward. People are dying. We know better, so we should be able to do better.
Thank you.
Whew, friends, we heard it today. We're a school of public policy. We have work to do, hard work. I am energized by this talk and by interacting with you, Dr. Sealy-Jefferson. I'm ready, and I thought your talk was fantastic. Thank you so very much. Thank you all so much for coming.
Thank you all.